My name is Stuart Schlossman. I'm president and founder of MS Views and News. I too have multiple sclerosis. This program is about understanding disability progression in multiple sclerosis. I want to get everybody to thank our sponsor of this series is Sanofi. All right, so I want you to all give them a round of applause, please. Thank you. Dr. Augusto Miravalle is Chief of Multiple Sclerosis and Neuroimmunology Division and Professor of Neurology at Rush University Medical Center. What a tongue twister, right? An internationally recognized expert in multiple sclerosis. He has over 15 years of experience in clinical care, education, and research, trained at Loyola University Medical Center and Harvard University. Dr. Miravalle has held leadership roles at the University of Colorado and the University of Florida. His work integrates advanced imaging, innovative therapies, and lifestyle interventions to improve brain health. Let's welcome Dr. Miravalle. And the doctor will speak with you for about 35 minutes, and then we'll do another Q&A, and that's it. Thank you.
Excellent. Well, thank you, Stuart, for that wonderful introduction. So what I'm hoping to do with you next is try to discuss a little bit about lifestyle interventions that go beyond exercise. But also the most important thing, not only the why this is important, but how are we going to incorporate this knowledge, this scientific evidence of the benefits of lifestyle interventions in multiple sclerosis into a patient's day-to-day life. So before moving there, I would like to bring us all up to speed into the contemporary view of the clinical course of multiple sclerosis and how is our understanding of the different mechanisms that go beyond that. So I'm sure all of you heard about the terms that we've used for decades: relapsing remitting MS, secondary progressive MS, primary progressive MS. And perhaps you heard that we are moving away from those terms. And the reason is that we are now starting to learn that the pathology, so the mechanisms that are responsible for these events, the relapses and the progression, are common in every MS patient. And so what we see, the clinical manifestations, in a sense, do not tell us that those are different types of MS, but it's just what we can see, the tip of the iceberg. So here, what you see represented in the slide are these bars that represent what we call relapses or clinical events. And the definition is there for those of you who are perhaps not familiar with what a relapse is. But I'm sure all of you know, because perhaps you experienced a relapse, which is the onset of deficits that last for at least 24 hours, usually last for days or weeks, that often resolve, but very rarely resolves with complete restoration of function. And that's what you see here, is that the bars never truly come back to the baseline level. So we are cognizant on the fact that patients after each relapse, there is going to be some residual functional loss on whatever symptom the relapse actually affected. That's one of the reasons why it's critical to be very proactive in preventing relapses. Because first of all, it's not fun to have a relapse, but also we know that there is a price that you're going to pay if we allow relapses to happen. So as you can see in the slide, over time, one observation that you may see is that the frequency of relapses decreases over time. And we've seen that a lot in natural history studies, which we see that as patients it's getting old, the frequency of relapses decreases over time. Have you heard of that before? So in the past, doctors used to tell patients, you are in remission. Well, that's not necessarily true. We know that the pathology of MS continues, but the frequency of relapses decreases. And that has to do with the fact that the immune system, or the immune system that is responsible for those relapses, is aging the same way you are aging. So what we see is that it's a term that perhaps you heard called immune senescence, results in the number of relapses and lesions that accumulates over time decreases as patients age. So I'm going to introduce a new term that perhaps you heard, which is RAW. which is a term that was coined, I will say, a decade ago, which stands for relapse associated worsening. And that is a way for us to try to understand if a patient accumulates disability over time, what are the contributors to that disability? How much of that comes from an incomplete recovery of a relapse? And how much of that comes from progression, which I will describe in a minute. So if we can tease that out, RAW is, by definition, the accumulation of disability that comes from an incomplete recovery of a relapse. And it's important to understand that, at least from a medical scientific standpoint, because we are becoming more nuanced in MS. We are trying to understand our therapies that are very effective at preventing relapses and lesions. How is that efficacy translates into disability? And in order to do that, we need to understand, what contributes to disability. So ROI perhaps is a term that you heard or you will hear. Here in the slide, I introduce another variable, which is these dark-looking stars. And they represent lesions in the brain, in the spinal cord, in the optic nerve. And one observation that you may see is that the number of lesions is larger than the number of relapses. And perhaps that's not new to you. If you go back in your life, maybe you had a first relapse 20, 30 years ago, and someone did an MRI and you had 10 lesions. And perhaps at the time you thought, wait a minute, how is that possible? How is that possible that I had only one clinical event and I had all these other lesions? What are those doing to me? Had that happened to you? I see a lot of some nodding yes. And I will explain to you in a minute what are those lesions affecting, but they're affecting something that we call the brain reserve. And I want you to remember that term, because understanding brain reserve is one of the ways by which we can understand many things in MS, including the benefit of exercise, including this concept that someone asked before, after I do exercise, I feel tired. And what is happening there? Why am I so tired after exercise? And the follow-up to that question is, but if I continue to exercise, my levels of fatigue will get better. And that understanding brain reserve will help you understand why, with exercise over time, things get better. So going back to the slide, so most of the lesions that we see on someone with multiple sclerosis are affecting the brain reserve, are affecting areas of the brain that perhaps are not linked to a function that you need to use on a day-to-day basis. The way I explain that to patients is, imagine your brain from a functional standpoint as two compartments: the brain that you use every day and the brain that you have for reserve, similar to your bank accounts. You have your check-ins and then you have your savings. And like the bank accounts, when we are born with a lot of brain reserve, with a lot of savings. And over our life, with or without MS, as we acquire new functions of the brain, let's say as you learn new things, as you learn how to bike, as you learn a new language, as you learn something that you learn in college, well, what is happening there is that you're using that brain reserve, specializing that into a new function, a new role, a new knowledge, and then transferring that back to your check-ins, and then you're using that part of the brain. So it's very plastic. See, this concept of transferring neurons, in a sense, they are not moving, but you are specializing those neurons into a new function, is something that is happening constantly in our brain. And a term, neuronal plasticity, means that, just the adaptation of the brain to respond to a new activity. But neuronal plasticity also can be a function of the brain to respond to a negative effect on the brain. In this case, will be inflammation, lesions, or relapses. So the brain is doing that in the background for you. The brain, after a lesion happened, is going to readapt, is going to reorganize itself to try to compensate for that loss of function or for that pathological event in the brain. So neuronal plasticity is a good friend of ours. It not only allows us to super specialize our brain and acquire new functions, but also is a normal mechanism by which the brain adapts to pathological situations, in this case, MS. So part of the reason why functional recovery improves is because, well, lesions sometimes get smaller, its swelling goes away, but also the brain will rewire itself, will adapt to that situation to try to acquire that function back. But there is a price that we pay if we allow lesions to accumulate over time. Similarly to relapses, we don't want to see new lesions over time because we know that even though those lesions may not be causing symptoms earlier, they are affecting your brain reserve. It's like someone stealing money from your savings account. Even though you can still pay the bills, even though you can still do the things you want to do, you don't want that to happen, right? Because we know that we will need that brain reserve as we get older. Is that clear? Good, excellent. But this is not all in MS. This is not the whole story. This is just half of the story. There is another situation that is happening in MS that we call progression. And this progression is, we are starting to understand the mechanisms behind the relapsing portion of MS as well as the progressive portions of MS. And perhaps you heard terms like smoldering inflammation or chronic inflammation. I see some yes nodding heads. So that's just a term that we are trying to still get our heads around, but appears to be that, it's a different type of inflammation that is responsible for this progressive phase of the disease. In a nutshell, basically, we starting to think that the acute inflammatory response that is responsible for the relapses and the lesions is usually triggered by the periphery outside of the central nervous system. Immune cells get activated outside and perhaps learn to go after something called myelin. And after they do that, they're going to try to reach the central nervous system, go after that, and attack myelin. In that process, not all these cells are going to leave the central nervous system. And some of those immune cells that are activated may stay in the central nervous system and they aggregate into follicles. They kind of like create these clusters of cells that actually stay within the central nervous system. And the thought behind the current understanding of smoldering inflammation is that compartmentalized inflammation is responsible for another type of damage to the brain. And that damage to the brain clinically manifest as a slow decline of neurological function. And that decline, which is represented as this growing slope, it's different in every patient. In some patients, that decline is very minimal, very minor. In some patients, the slope of the curve is very abrupt. And that's very different in anyone. Perhaps genetic factors, environmental factors, perhaps lifestyle factors play a role into determining the slope of this curve. What are the symptoms of progression? Perhaps you have experienced some of those, which is a sustained, which is defined there, the sustained decline in function that lasts for at least 6 months and is independent of deconditioning. And that's something that loops us back to the previous talk that Dr. Model mentioned before, which is, of course, if we are out of shape, if we want to walk, it might take us a little bit longer. But if we continue to exercise, that resistance to exercise might improve. So that's not progression. That's just deconditioning, being out of shape. Progression is something that is like, well, I used to be able to walk, let's say, a mile 2 years ago. And despite continue to do exercise and engage in physical activity in the same way, I can now only walk half a mile. And that's consistent over time. So that will be an example of progression. Fatigue is another example of progression, particularly when the fatigue interferes with your activities of daily living, when it's sustained, but it's difficult to truly do the things you want to do because you are exhausted. Cognitive decline will be one. And it's not a cognitive decline that is similar to what we see in Alzheimer's disease. It's different. It's more of that processing speed, ability to multitask, ability to keep attention for a prolonged period of time. And when that decline is sustained, that's when we start seeing some of the symptoms of progression. But some of you, perhaps if there is someone in the audience that doesn't have MS, may be thinking, but wait a minute, aren't those symptoms common in aging? Like our resistance to exercise decline, our attention goes away or decline, we are more tired. And it's true, some of the symptoms of progression also are symptoms of aging. And that's why sometimes when patients have a very subtle amount of progression, it's very hard to determine the difference between aging and MS progression. And our goal with everything we are doing in medicine these days to incorporating lifestyle interventions is to drop this line of progression so close to aging that at the end of the day, well, we don't know what is causing that, but I'm glad you can still do the things you want to do. And I think, and I believe we are getting closer to that phase. So another term that I'm going to introduce you to, in case you have not heard that, is called PIRA, which stands for progression independent of relapse activity. So when you put the two terms that I discussed today, RAW or relapse-associated worsening, and PIRA or progression independent of relapse activity, those are the two terms that now we are using to say, well, what contributes to progression disability in multiple sclerosis? So all both together roughly account for 50%. If we, let's say, someone with MS doesn't receive therapies and we let the disease continue as its natural course, RAW and PIRA will contribute to around 50% each to the amount of disability that someone will have. But there is a third component, and this is our friend, which is called the brain or neurological reserve. And that's the one that actually we are paying a lot of attention these days to try to say, can we not only preserve that savings account in the bank account, that neurological reserve, not only preserve, but can we improve that? Can we bring more money into that savings account? And the answer is yes. In some situations, it's possible to do that. So let's imagine that someone goes through life and in multiple sclerosis, perhaps have some relapses. Those relapses appear to improve, but perhaps over time there is this disability that accumulates, but that patient does not have any symptoms of progression. Well, that will be situations like that the neurological reserve is masking, in a sense, everything, or at least most of the things, and that's why patients perhaps don't have the symptoms of progression. But in most patients, this is what is happening, that the neurological reserve, in a sense, masks those early symptoms of progression. But over time, and usually it's around 15 to 20 years from diagnosis, that's when we see that there is this exhaustion of the neurological reserve, of the savings account, that leads to now the symptoms of progression becomes clinically evident. And that's the point in which in the past, we used to say someone going from a relapsing remitting MS is now in what we call a secondary progressive MS. But as you can appreciate now that you know the background story, that doesn't mean that the disease changed. That doesn't mean that progression just started now. What that means is that now the symptoms of progression are no longer being masked by that neurological reserve. And that's why patients are starting to notice the consequences of progression. But progression started here. Are you following me? Very good. That's one of the reasons why now in MS, we advocate for early access to highly effective therapies, because we know that this is the time that we have the highest chances on stopping all the processes, the ones that we can see and the ones that we can't see. And this is the time that actually we know that we are affecting relapse rate reduction, we are affecting lesion load accumulation, and we have the highest chances of dropping this line and preserving neurological reserve. If you wait until you're in your 60s to start highly effective therapies, probably you're not going to get all the benefits and you may get the side effects of aggressive immune suppression. So, but of course, we want to complicate matters, right? So now that I explained the brain reserve, I'm going to tell you that there are different types of brain reserve. And I think what this, the value of understanding this is the fact that, again, it's very complex. So one type of brain reserve is what we call the passive brain reserve. And I like analogies, so I'm going to give you another analogy now. Imagine that the brain is like a computer, and you have the software and then you have the hardware. So the hardware will be how big the brain is, the structure of the brain, the number of neurons. That's determined genetically, that we are born with a brain. All humans have very similar amount of neurons, very similar amount of brain volume. Actually, women have larger brains than males, so I hate to tell you that, males. And women, you cannot use that in an argument against males, but it's true. The volume actually is determined by all these factors that we have little control over. And that is what we call the passive brain reserve. And is that affected by MS? Yes. So one way in which we can measure the passive brain reserve is by measuring brain volumes. And now we have some sophisticated softwares that we can apply to an MRI, and we can actually understand the amount of brain volume that patients have. And at Rush, we are working with a program called icometrics, which allows us to measure brain volumes and understand, what is the size of the brain of patients and what is happening over time in terms of reduction of those brain volumes, something we call brain atrophy. But perhaps the most hopeful part of the story is what we call the active brain reserve, which is not linked to the size of the brain, but is linked to the functions of the brain. How are we using that brain? How many software programs we input into that computer? And of course, the more programs we put into the computer, the more functional that computer is going to be. Similarly to the brain, the more we challenge the brain, regardless of its size, the more specialized the brain is going to become, and the better the functions the brain is going to do for us. So this is where lifestyle choices play a huge role into improving that active brain reserve. So the things we do with our life, the things we eat, how we sleep, the toxins that we decide to bring to our brain, like smoking or alcohol, all of that is going to affect some of those factors positively, some of those factors negatively into that active brain reserve. And this is usually what I explain, that regardless of the size of the brain, you could be in the 1 percentile of brain volume, but you can still improve brain function. And because those two things are actually separate and in a sense influence one each other, but actually we can work in hoping to preserve functional loss and improve function by looking at the things that we choose to do with our brain. So, can we see all of that in an MRI? Well, not with the standard MRI, but with something called functional MRI. We are able to actually measure these principles and understand them. So I'm going to give you a little quiz here. I might pick on someone on you in the audience, so you better pay attention. So what you're seeing here is an MRI of a healthy control. So this individual doesn't have MS. And that individual was asked to do some movement inside the MRI. It's something called finger tapping. So they asked the patient inside the MRI machine, just move your finger. And they were actually looking at what parts of the brain get activated when you're doing that activity. And when you see here in orange and yellow are the areas of the brain that got activated by triggering that movement inside the MRI machine. What the investigators did next is they brought an MS patient of the same age and the same gender to try to eliminate all variables, and they asked the patient to do the same thing. So I'm going to ask you, that you're in the first row, when you compare the amount of red and yellow in the healthy control here versus the MS patient there by doing the same activity, which one do you think had more cortical activation? The MS patient, exactly. So what you're seeing here is that the MS patient, in order to accomplish the same task, had to use more brain, ultimately, what is happening here. I'm going to ask you, so if someone has to constantly use more brain to do the same things that someone without MS, how do you think the brain is going to feel at the end of the day? Exhausted, exactly. So that's one of the ways by which we can start to understand fatigue in MS. What is happening here is that MS patients, and perhaps due to demyelination and inflammation, they're constantly having to use or activate larger amounts of cortical activities in order to perform that function. So but I always like to give you good news. So this is understanding fatigue, but can we change this? Can we modify this system? Can we make the system more efficient to hopefully drop the amount of cortical activation and improve fatigue? And the answer is yes. So I'm going to skip to this slide. So the investigators in this study looked at an MS patient at baseline. And you can see that the MS patient at baseline had a lot of cortical activation. You see a lot of yellow and orange by performing that motor activity in the MRI. Then they enroll these patients into a 3-month physical therapy and rehabilitation program to enhance function and hopefully improve function. At the end of those 3 months, they did another analysis with a functional MRI. And what you see here is the same patient 3 months after therapy. So I'm going to ask somebody else. So when you compare the amount of orange and yellow here versus the amount of orange and yellow there, which one has more orange and yellow? The first one. So the same patient over time, just by doing 3 months of physical therapy, was able to reduce the amount of cortical activation needed in order to perform the same task. And guess what happened to that person's levels of fatigue? Improve. So that goes to your question. Yes, early on, if you're deconditioned, if you haven't exercised for a long time, you're going to do exercise and feel very tired. And that happens. That's why I always tell my patients, it gets worse before it gets better. But keep doing it safely, keep listening to your body, but keep doing it, because over time, when you keep challenging that function, we know that the system is going to become more efficient. And we learned that not only in MS. Let's say those of you who learn how to bike, and I say that because I learned how to bike when I was 27 years old, so don't tell anyone. But if you learned to bike when you were a kid, perhaps you experienced that. Early on was difficult and you fell a lot and it was hard to coordinate all these movements. But as you continue to practice that, then the movement became so natural that you can bike and talk and listen to music. Because all of a sudden, the neurons, the pathways that are involved in the process of biking became so efficient by training. And the same principle is preserved in MS patients. And that's why we always say, well, yes, exercise might make you more tired early on, but keep doing it. Work perhaps with a physical therapist or someone that actually understands the type of exercise you need, but be consistent. As a matter of fact, I believe the guidelines also recommend everything that we discussed before for at least 6 months, but consistent at least 6 months. That's when you start seeing the benefits of exercise over time. This is a slide that I borrowed from Dr. Model, and I'm not going to read that because he's right here. But he already mentioned to you many of the benefits of exercise that actually go beyond just simply the immediate benefits on the neuromuscular system, because actually go into relapse rate reduction, lesion volume reduction, and my favorite one is improvement in the volume of certain parts of the brain. So we talked about brain volume loss. Certain parts of the brain, actually the volume increase. So that's something that we continue to pay attention to. So the Canadian guidelines were discussed before, so I'm going to skip this part. And as Dr. Model mentioned, it's on us and healthcare providers and neurologists to advocate for exercise. And I know that it takes time, but it's important. Similarly to the same effort that we put in advocating for disease-modifying therapies, we need to advocate for exercise. And it takes more than just simply telling someone before they leave the room, you need to exercise. It truly takes an effort. Let me tell you what we are doing at Rush. So we have what is called a brain health program. And patients have the opportunity to meet with a nurse practitioner after they see a neurologist on one-on-one basis. And that visit is an hour-long visit. And this a provider is going to go over questionnaires about your sleep, about your diet, about your exercise, and most importantly, establish goals. And she uses something called SMART goals, which is a great framework to actually determine goals that are specific, that are attainable, that are relevant, time-bound. And after the patient and the provider agreed on the goals, whether it's improve exercise by 10% or decrease certain components on my diet by 1%, then the subsequent visit, it's all about keeping people on the right track. And making sure that actually we help patients walk through this sometimes difficult process of not only incorporating healthy lifestyle choices, but staying in the right track of lifestyle choices. So the program is enhanced by a series of educational offerings. We have something we call the Masterclass. That is a 3-week online program. It's absolutely free. That patients have access to videos and live sessions to try to understand more nuanced into the benefits of diet, for example, which is very important, and exercise. For example, the benefits of sleep, management of comorbidities, as well as an ongoing series called Conversations on Brain Health that happens the second Monday of each month, that patients can actually continue to learn longitudinally as they go through the journey in multiple sclerosis. So a few words about nutrition. And we know that what we eat has a profound impact in our brain health, but also in multiple sclerosis. And perhaps you heard about something we call the microbiome, which is all these gut bacteria that we have. And so there was a recent study looking at, for example, identical twins, one with multiple sclerosis and one without multiple sclerosis. And they had 10 pairs of twins like that. So in which one twin had MS and the identical twin did not have MS. And what they did is they transplanted the microbiome, which is a fecal transplant, from the twins to an animal model that is predisposed to develop MS. And what they learned after that study is that the fecal transplantation, meaning the microbiome of the twins with MS, was able to trigger MS lesions in the mouse model, whereas the microbiome from the twins without MS did not trigger MS lesions. So what this is telling us is that some of the composition of the bacteria that we have in our gut may trigger inflammation that ultimately could result in MS-like lesions. So we now know for decades that the gut microbiome has a direct effect on inflammation. And how can we modify the gut microbiome? By the things you're doing right now, by eating. So what we eat is going to determine the composition of the bacteria in the gut. And so look at the gut microbiome as those tiny little soldiers that are there to just break down the components of your diet and eliminate the bad ones and bring the good ones to your system. So if all you expose those microbacteria is trans fats or salt or the unhealthy foods, well, they're going to be specialized to work for you in modifying those nutritional components. And those bacteria that are being linked to a high trans fat diet are the same bacteria that actually have been linked to increased inflammation in MS. And that's the link that we are creating now of saying if someone follows a diet that is very high on saturated fats, those delicious fats that we all like, but they are really bad for you, like the fat in bacon, the fat in the ground beef that has high fat content. So that dietary component is going to lead to a microbiome that is going to be more pro-inflammatory. We are also learning that on the contrary, diets that have a high content in fiber, in blueberries, in greens, in leafy greens, in vegetables, diets that has the good fats, the unsaturated or the polyunsaturated fats, like seen in avocados, in olive oils, in the nuts, for example, that we can incorporate in our diet. Those are components that actually have been linked with the less pro-inflammatory composition of the microbiome. And actually, you can change the entire microbiome in 4 weeks. So when the moment you start a new diet, if you're consistent with that diet, you have a profound effect, and it's relatively quick, the effect on changing the microbiome. So that's another of the things that actually we work with our patients in trying to first educate in what are the good components of diet, and two, how to change your diet. I'm sure you heard of many names associated with diets. The ones that consistently have the largest amount of evidence is what we call the Mediterranean diet, and the modified version of that was developed at Rush called the MIND diet. So the MIND diet was developed to enhance the Mediterranean diet by decreasing the amount of sodium. We know that sodium or salt in the diet is another pro-inflammatory component. We recommend less than 2 grams a day of sodium. And if you start looking at, for example, processed meals, you probably have that already in whatever you're eating that comes in a can or in a packet. And that's why we always say, well, if you can't, and if you can afford, buy fresh produce and make your own meals, because at least you have control in how much sodium you put into your diet. All right, going to other common lifestyle intervention is vitamin D. Perhaps you heard now that vitamin D deficiency has been linked with not only an increased risk of developing multiple sclerosis, but also lower levels of vitamin D has been linked with worse clinical outcomes. And for that reason, we recommend that the levels are checked. And if patients are deficient, we supplement with oral supplementation of vitamin D. We're trying to aim for levels of 70 nanograms per deciliter, which is higher than the usual range in which the laboratory is going to give you the result. So if you do a vitamin D check and the results look normal, still check with your neurologist, because most likely we want them higher than the upper limit of normal on that blood test. For the most part, most patients need between 5 to 10,000 international units daily to vitamin D. And the same thing with exercise, has to be consistent for 6 months before we see a change in the levels. And of course, my least favorite thing to do to our body, which is smoking. Smoking has been linked to an increased risk of developing MS. Particularly early on in life. So if you have kids or someone in your family ask you, what can I do to decrease my risk of MS? Number one, don't smoke. Number two, check your vitamin D levels, and if you're deficient, supplement that. And also childhood obesity has been another factor that has been linked with an increased risk of MS. So make sure that your family members keep a normal weight. But also cigarette smoking in someone with MS has been linked with increased inflammation, increased rate of relapses, and of course, progression. So now we have guidelines similarly to exercise on lifestyle and brain health interventions in MS, and these are the main pillars of that. Number one is understanding the importance of brain health, and that's why these type of programs are important, to raise awareness on the importance of brain health. What are the pillars? Also, earliest possible referral and diagnosis. Talking about what I mentioned earlier, time is brain. So early access to highly effective therapies is critical. Living a brain healthy lifestyle. And no matter where you are in your journey, similarly to exercise, even if you had MS for 45 years and MS unfortunately led to a lot of disability, you can still benefit from the incorporation of healthy lifestyles into your multiple sclerosis. Of course, regular monitoring of your disease activity. And last but not least, none of this will work if you don't do it or if you don't incorporate it. So the discussion about lifestyle interventions should be shared decision-making between a provider and a patient. And sometimes you're not in the right time to make these changes. Sometimes, particularly in the newly diagnosed patients, I wait. Let's just wait a couple of months before we have a conversation about diet. Or sometimes I start with exercise first and then we go to diet. My favorite way to get into the diet is first starting with exercise. And I recommend after each workout that you decide to do, maybe just do a smoothie that is incorporating all these healthy things like blueberries and bananas and maybe some creatine. Maybe you put some kale and spinach and you get creative. And that way it's easier to start incorporating things before you remove the the bad players that perhaps are important. Another principle that I like to work with patients is called marginal gains. That's a principle that is very popular in athletic training, which is if you have to change a complex system that has multiple variables, choose to improve by 1% in each variable. And so if you look at marginal gains and you apply that to MS, it will be, well, you know the pillars, you know nutrition and exercise and sleep, weight control, smoking. Rather than focusing on one and trying to change that one activity, go from 0 to 100, just look at everything you do and improve by 1% each category of your life. That is an easier way to remain in the right track. Also a great way to give yourself credits, because we all like to improve. So lower the expectations on your goals and make those goals and expectations consistent. So that way you feel good about it, and you feel good about your changes in your diet, and you feel good about the exercise you're doing, and you become more consistent over time. I believe that's my last slide. So with that, I'm going to say
Thank you very much.
we open to questions.
Thank you very much. Everybody give him a round of applause. First one. This person has PPMS and is still moving around freely, but wants to know what the difference is of PPMS for why is there such a vast difference between those that are unfortunately in chairs versus his ability to still run around.
Yeah, so good question. As we briefly mentioned, we are moving away. I mean, there are some subtle difference between primary progressive multiple sclerosis and relapsing onset multiple sclerosis. And perhaps those difference has to do with, a larger proportion of lesions affecting the spinal cord in primary progressive MS patients, but the disease itself is the same. And the recommendations apply to all, regardless whether it's primary progressive or relapsing MS. These recommendations apply to everyone. And what we do is we tailor the goals of exercise or diet based on someone's particular needs. And so it should be personalized. Whether there is primary progressive or not, it truly doesn't change the recommendations.
It was very interesting that what you're discussing has to deal with just healthy eating. It helps everybody. But the one particular thing I was interested in when you were talking about vitamin D, I just read an article in Scientific American that they said it's not necessarily vitamin D that's helping MS, it's the UV rays. And they were talking about UV light rays, a very specific form. Have you heard anything about that? That they say, to have, 5 minutes each side of your body for a UV rays is more effective than vitamin D specific.
Yeah, so a couple of comments to that. So the levels, most of the studies done with vitamin D and MS, it truly comes down to the levels in your system. And that's why the dose is adjusted based on the levels. And that has to do with the role that vitamin D plays in immune responses. How you reach to that level, there are different mechanisms. One is by just sun exposure to sun. It is for someone that is deficient, it will take many hours of sun exposure to truly get to those levels. And that's why we recommend to do oral supplementation of vitamin D. And of course, we didn't talk about this, but there are many negative health consequences of sun exposure, whether it's skin cancer or even aging. And that's why the current recommendations is, supplement orally if you are deficient. Being outdoors, no doubt that brings benefit. I wouldn't take that as, if you spend 5-10 minutes every day, I wouldn't take that as saying, well, I've done enough for my vitamin D. I still will recommend oral supplementation, particularly if someone is deficient.
And I live in Florida. We stay out of the sun, by the way.
I have a few questions, but one of them was, can exercise slow down the compensatory loss of neural reserve?
Yeah, so that is a complex question to answer. And so probably we don't have scientific evidence to say that, but what we know is that with exercise, you're affecting what we call that active brain reserve, which is indirectly helping that compensatory mechanisms of the brain. In terms of measuring that, there were some studies looking at, and briefly mentioned in one of the slides, of brain volume. Can we drop the rate of atrophy by consistent exercise? And some studies showed that yes, particularly in some of those what we call subcortical gray matter structures. Interestingly, I don't know what Dr. Model thinks about that, but one of the areas of the brain is one of the few areas that actually you can regenerate new neurons, something called neurogenesis, which is in the hippocampus, in that deep in the memory center of the brain. And consistent amount of exercise was one of the few activities that helped to enhance neurogenesis in that part of the brain. So I think that the benefits of exercise on brain volume, we are starting to understand, but everything we are learning is that it could be beneficial.
Okay. And then if a patient was on like Tysabri and then they got off of that and then started Briumvi, but they haven't been doing well on Briumvi, would you recommend to go back on the Tysabri? Would that be safe?
So that's a good question. I will refer that question to maybe you and your healthcare provider. And the reason I'm saying there are many factors that play a role when determining the right therapy. And also, what do you mean by not doing well? So if there is evidence of disease progression or new lesions, well, yes, that probably should be taken into account. But sometimes when we switch from medications, patients don't feel as good. And that feeling good effect is hard to measure. But there are different strategies we can take when that switch happens to help patients feel better. So I will say just any conversation about sequencing or change of DMTs, it has to be done on a one-on-one with your neurologist to take a look into everything else that is happening.
Thank you. We're on again. Thank you. By the way, a lot of people say that I'm just speaking from a patient's perspective here for a second. I hear from people all over the place that say my drug is not working. They expect themselves to just feel better by using the medication. The answer is that the medication is not designed to make you feel better all of a sudden. It's just designed to slow down the course of the disease. And that's what most patients don't understand, which is what more patients need to learn to understand. So that's why their doctors need to be more vocal with them. Okay, next question online. Sorry for that, but I had to say it. Person wants to know if stress will play a factor on their disease course.
Yeah, absolutely. Particularly chronic stressors. So someone has a consistent high levels of stress in their life. It has a profound effect on inflammation in all these clinical outcomes. So I will say stress reduction, mindfulness. So I mentioned about the neurogenesis in the hippocampus. The other factor other than exercise was actually mindfulness-based therapies. So anything we can do to mitigate stress, to reduce stress, that should be done. Not necessarily just to help with your MS, but also improve quality of life, has a profound effect in mood and also participation.
Thank you. Next one. Person knows it's not an exact science, but how do you know when someone has progressed from relapse remitting to SPMS?
Clinically, usually that happens when we can identify that those signs of progression over time, that chronic, persistent, continuous amount of disability or functional loss that lasts for at least 6 months.
Thank you. Next one is, can a person have progression or relapses without new MRI activity?
So so sometimes happens. So when symptoms occur and we do an MRI and the MRI is unchanged, we don't ignore those symptoms. Sometimes there could be a recapitulation of previous symptoms that come from a lesion that was previously formed. Often we see those situations and we label them as pseudo relapses, but that doesn't mean they're less important. That means that we are not able to capture a new focal amount of inflammation. And the usual triggers for pseudo relapses are infections or fever for unknown origin, stress, overheating sometimes does that. So it's possible to have symptoms that come from previous lesions.
What is creatine and how is it helpful when added to the diet for an MS patient?
So creatine is another form of taking amino acids or increase your protein content. And I'm next to an expert in exercise, so I don't want to embarrass myself, but it's my understanding that particularly when we are doing strength training exercise, that you want to make sure that you have enough protein in your diet intake to help with that muscle mass gain. And also, I heard many nutritionists actually recommending that the amount of protein varies in our course of life. And as we age, also, we may need to have increased amount of protein in our diet to compensate for the natural loss of muscle mass, something we call sarcopenia, that occurs in all of us as we get older. So the ideal situation will be if you have access to a nutritionist, to actually sit down with them every couple of years and see, review your diet. That's another reason why we have this brain health clinic, to help patients actually customize the dietary intake based on their particular needs.
Thank you. Next question's here.
Yes, thanks for your time. I'm curious if you guys have had any experience with marijuana. My experience has been my neurologist suggested it back in 2015, 2016, when here in Illinois it became legal, and it was to prevent me to be in a lot of pain. I was dealing with a lot of side effects with the pharmaceuticals. I didn't like how they felt, and I dealt with a lot of side effects. So I'm curious if there's been anything that's been official with that study.
Yeah, so a lot of studies are actually trying to understand the role of CBD, which is a cannabinoid portion of the marijuana, that in health in general, in neurology and also in multiple sclerosis. The benefits that I've seen from studies are mostly, as you mentioned, on spasticity and to some degree control of pain. The negative side of marijuana use is decreased processing speed, which is one of the functions that perhaps gets affected with multiple sclerosis, which is the speed by which your brain can process information. So like any intervention, you have potential benefits, potential side effects. So the recommendation of the use of marijuana should be taken into a one-on-one basis. For the most part, I don't recommend marijuana. I try to find other ways to help with spasticity and pain. But in some situations, sometimes it's the only thing we can do.
Thank you. Next.
Hi, yes. My daughter was diagnosed with MS 2 years ago. She's now 24. So we're trying to figure out and learn about MS. And we're trying to figure out her quality of life. And she has like lost mobility in her right arm and she has a foot drop. So we're trying to see what her quality of life would be looking like in the next upcoming years. Is it anything that would help with the mobility in her right hand and the dragging her foot drop?
Yeah, great question. So one of the things that we recommend for any situation in which there is decreased mobility or foot drop is have a visit or two with a physical therapist to assess the functional capacity today and determine the goals. There are different, we talked about some of the exercises for foot drop before. There are also some devices that we can use to enhance mobility and movement. There's a couple that you can put under your knee that has been developed, Walk8 and Bioness. There is a newer form called a Psionic, which is a mesh that patients can put in the leg. And that's less bulky and helps with electrical stimulation to the lower limbs. So there are different ways that we can help to restore function early on. But in general, if there is a decreased amount of movement, the recommendation is to improve the amount of movement by moving more. And that's where, again, with physical therapy, rehabilitation, and exercise plays a critical role. The do not do, absolutely no, is if you have weakness on the foot, don't leave it alone. It's not going to get better by itself. We have to do something to improve that function.
But it does get better over time.
It could with the right treatment.
Yes, thank you, Dr. Miravalle and Dr. Motto. Thank you for wonderful presentations today. My next question is about the drug. My pronunciation is probably bad. Tolebrutinib. That just a few days I learned that it was approved in Saudi Arabia. And is that a hope? Is that hopeful news for those people with progressive? Because this is what I read about it.
Right. Yeah, good question. So tolebrutinib is one of those medications that we are all hopeful will be approved in the US and hopefully in the next 6 months or so. It's part of a different class of medication. We'll call that BTK inhibitors. So in a nutshell, we talked about the two types of inflammation, right? The acute inflammation outside of the brain and the chronic or smoldering inflammation inside of the brain. In both types of inflammation, there is one type of immune cell that plays a role. We call that B cells. And perhaps you heard about those. Those are the cells that target ocrelizumab or Briumvi. So BTK inhibitors have the potential to work on B cells outside of the brain, but also inside of the brain, which is something that we currently don't have a lot of access to. Most of our therapies work outside of the brain. So the hope with BTK inhibitors like tolebrutinib is that may be affecting both types of inflammation, acute inflammation as well as smoldering inflammation, which is a current unmet need. So the phase 3 clinical trials showed actually benefit on patients that were inactive, meaning no relapses, no MRI activity, and still progressing, on decreasing the amount of progression. And that benefit was completely independent on MRI activity or in other patients in other studies in relapses. So it's showing some promising results in truly affecting that chronic amount of inflammation that leads to progression, whether it's in primary progressive or in secondary progressive MS patients. So a lot of hope.
Thank you. It was also just approved somewhere in Europe yesterday, so not just Saudi Arabia.
Yep.
Hi. Yes, I have actually two questions. One is I was recently on a MS support call, and someone was talking about a medication. I don't know if it's holistic or not, but it's called LDN, a low dose something. Naltrexone, right? And it's supposed to help for some people with MS, spasms and fatigue. What is your take on that?
Yeah. So there was a lot of hype about low dose naltrexone, I will say 15 to 20 years ago. And some interesting research was done to try to understand the benefits. For the most part, we don't have a lot of scientific evidence that it helps. So it is a peripheral anti-inflammatory medication. It's very broad, the effect of the type of cells and inflammation that it actually benefits. And for the most part, none of the studies that looked LDN translated into a measurable benefit in MS patients. So I don't use LDN for the management of spasticity and fatigue. I tend to do other things, and we talked a lot about fatigue management with exercise and sleep. I mean, there are so many factors that go into that. For spasticity, actually, there are many strategies we can use. Some of those are medications. Some of those are things like acupuncture, massage, rehabilitation. Sometimes we use medications that are oral medications like baclofen or tizanidine. Sometimes we use Botox injections. So there are different strategies that actually help patients with spasticity feel better.
Yeah, my other question is also on this same call. It was a number of people on there who were either approaching 60 or it could have been well over 60, maybe tapping on 70. And some of them had never, ever taken DMT, disease modifying. Right. So, and I heard in your presentation that if you don't start off in something early on, then you might pay for it, tremendously later. So are those people who are 60 or over and who have been dealing with MS for a number of years but never took a DMT, are they just kind of like lost and have to?
Yeah. So the way I explain that is taking a DMT is equivalent to buying a policy insurance for your car to have car insurance, right? So you're doing something now to help deal with a problem that you don't know is going to happen. But if you drive every day in Chicago, if you drive for 20 years, most likely you're going to get an accident. So when you see someone with MS today, you don't know what's going to happen in the future, right? But most likely, new lesions can happen and more relapses will happen. So if you have something that you can use today to prevent that, you should use it. So when I hear those stories, to me, is the equivalent of someone driving in Chicago for 40 years without car insurance. Well, they got lucky. But I don't think we can apply that principle to say everyone should do the same, because it's kind of risky.
If BTK becomes available, can that be used as a combination therapy with something currently available?
That will be fantastic, but I hardly doubt our insurance companies are going to allow us to use both. So no, unfortunately, will be approved, if approved, as monotherapy.
Okay.
But I will argue that exercise is a disease-modifying therapy. So you could use BTK inhibitors and exercise.
Thank you. What do you say to all those that are 60 plus whose doctors feel that they've been doing so well over time, they have not had a relapse? Let's take you off your medication.
Yeah, another important question. So we recognize that, as we mentioned before, inflammation that leads to lesions and relapses decreases over time. And we talked about that earlier. That's something we call immune senescence. Those are the two outcomes that the medications that we have approved are working against. So it is reasonable to say, after a certain time, if we have no evidence of lesions and relapses for a period of time, if someone is reaching those late 60s or mid 60s, might be a good idea to discontinue therapies. So there were now 3 studies looking at drug discontinuation in MS. And we didn't learn a lot of information that we can apply to everyone, with few exceptions. One is we learned that if we stop disease-modifying therapies before the age of 45, patients do worse. So it's a timing situation, right? So too early is not a good idea. So, and that's why usually before the age of 45 is not a good recommendation to stop therapies. After the age of 55 becomes very variable, and that's why that recommendation should be done on a one-on-one basis with your neurologist, looking into how was your MS before. And principle that always applies in MS is past behaviors predict future behaviors. So we look into your last 10 years. Is your MS being stable? No lesions, no relapses, no progression? And are you having any side effects from the medications you are taking? And we use all of that information to inform, well, you know what, it might be safe to stop therapies, but we don't have, unfortunately, recommendations that we can say apply to everyone.
So if a patient has the MFTHR gene, and it's known to actually cause the T cells to not function, would it still be safe to be on a medication like Briumvi if it's depleting the B cells as well?
Can you repeat the first part of the question?
If a patient has the MFTHR gene.
Oh, MFTHR gene.
Yeah.
Okay. Yeah. So we, prior to starting medications that will affect immune cells, like Briumvi, for example, we often do an analysis of baseline immune cells. So we do blood work to understand, do you have any baseline immune cell abnormality that we need to be aware of? And unless there is a profound immune suppression or decreased amount of immune cells, we usually use Briumvi or anti-B cell therapies in those circumstances. But it's important to monitor blood counts periodically, and I usually do that every 6 months, in which I look at immune cell repertoire. I look at, for example, B cell count, T cell count in those cases. We'll look at immunoglobulin levels to try to understand, are we looking at patterns that are within the safety parameters that we would like to see? But it's not a contraindication.
Excellent. Thank you. Let's give Doctor a round of applause. Again, we want to thank Sanofi for being our sponsor of this program series on understanding disability progression in multiple sclerosis. I want to thank our exhibitors that were here today. We had A&I, we had Professor Model's group. Keep calling him a doctor, but I think he wants to be known more as a professor. Genentech and Novartis. And so again, thank you everybody for being here, and safe driving home.